Hello, everyone. Thank you for joining us. We're going to let everyone get here into the webinar. We will get started momentarily. Thank you for joining. We will get started here shortly. All right, we will go ahead and get started. Hello, everyone, and welcome to the 2024 October PQA Quality Forum Webinar. My name is Amanda Ryan. I'm the Director of Education here at PQA, and I will be your host for today's session. Our topic today is leveraging pharmacists through an AMA program to improve blood pressure control. This webinar is sponsored by PerformRx. We thank PerformRx for sponsoring the webinar during American Pharmacist Month, which is a time to recognize pharmacists' contributions to healthcare and all they can do for their communities. PQA is grateful for PerformRx's support today and throughout the year. You can find out more about PerformRx by visiting performrx.com. And as a quick note, PQA does not endorse, recommend, or favor any organization or its products or services. And at this time, I would like to turn the floor over to Banal Patel, the Director of Clinical Initiatives at PerformRx, who will share some comments with us. Banal?
Thank you, Amanda. Good afternoon, everyone. At PerformRx, quality medication use is really at the heart of everything we do, and it's a key driver of our partnership with PQA. For over 20 years now, our mission has been to help our clients, physicians, and members achieve better health outcomes through effective medication therapy. We're proud to offer a clinical culture really focused on delivering high-quality care while also ensuring that our clients receive cost-effective solutions. This clinical-first philosophy sets us apart in the industry and guides the development of every product and service we offer. Central to this approach is our UREC-accredited drug therapy management program. Through this program, we promote safe, effective, and appropriate medication use by managing quality initiatives and fostering collaborations with both members and providers to help close gaps in care. We continually strive to create and refine customized clinical solutions to address the unique needs of our partners, ensuring that the services we provide deliver tangible, positive outcomes. Our long-standing engagement with PQA further underscores our commitment to quality. With our president, Jim Gartner, serving on PQA's board and our associates actively participating in PQA work groups, we are deeply aligned with PQA's mission of improving medication safety and adherence. PQA's dedication to enhancing and evolving quality measures aligns with our commitment to ensuring that our clinical programs consistently reflect the latest guidelines and healthcare standards. The relationship between PerformRx and PQA is rooted in the shared dedication to improving patient health through thoughtfully clinically driven pharmacy solutions. Together, we are working to ensure that every member we serve receives the highest quality, highest level of care, leading to better health and financial outcomes for all. Thanks for this opportunity, and back to Amanda. Thanks, Amanda.
You're welcome. Thank you so much, Banal, and thank you to PerformRx for supporting PQA. Before we get started with today's webinar, I'd like to remind you of our usual housekeeping items here. First, you can submit your questions to our speakers during the presentation using the Q&A feature at the bottom of your Zoom screen. We will answer as many questions as we have time for when we get to the discussion portion of today's webinar. Also, the webinar recording and the slide deck will both be made available to PQA members within a week following our presentation today, and you'll be able to find that in the Member Resources Library section of the PQA website. We will also post a recording of today's webinar on PQA's YouTube channel. And then finally, I'd like to remind you to please complete the 1-minute survey that will populate as you exit the webinar today. That does help to inform our future programming. And with that, it is my pleasure to introduce you to today's speakers. First with us, we have Zachary Crane, who is Associate Vice President of Clinical Administration at HopeHealth. Next is Claudiana Muftari, Director of Clinical Pharmacy Relations at the American Medical Association. And finally, we have Emily Reidenbach, who is a pharmacist at Grace Health. Thank you all for being with us today. And with that, I will turn the floor over to Claudiana.
Thank you, Amanda, and thank you, PQA, for the opportunity to spend some time today and to discuss some of the work that we are doing in cardiovascular space. This is the title of the presentation today, and we're going to try to highlight the leveraging of pharmacists through an AMA program to improve blood pressure control. The way we have structured our 40 minutes together today is we're going to start with an overview of the AMA MAP Hypertension Quality Improvement Program as a solution to a sustainable improvement in blood pressure control. I will speak very briefly to the different models of pharmacy services within the program that help support to drive success. And then my colleagues are going to speak more specifically into the two models, the population health and community pharmacy practice model. So AMA MAP Hypertension QI program. I want to start by really highlighting the role that AMA, who AMA is, and position AMA as the leader in cardiovascular disease prevention and management. The problem that we're trying to solve is really tied into the number of deaths that are occurring every year into the United States, that about 1 billion people die every year in the United States from cardiovascular disease. And to envision what that 1 million people look like, I'm sharing with you an image from the Wrigley Field, which is one of the biggest stadiums here in Chicago. That is 22 Wrigley Fields filled to capacity. And most of these chronic conditions, most of these deaths are preventable. And before I dive in to tell you a little bit about how AMA is working in this space, I want to very briefly mention to you who we are within the AMA. The work that AMA is doing in this space is really tied into the mission of the AMA, that is to improve the arts and science of medicine and the betterment of public health. And when we talk about betterment of public health, recognizing the impact that cardiovascular disease has in our country, that is what we are trying to solve for. So about a decade ago, AMA built this group that is called the Improving Health Outcomes. We are a team of about 50 different individuals with different backgrounds, multidisciplinary team. And besides clinicians, we have economists, we have public health experts, we have strategists, we have data stewards and technology stewards to help drive, and researchers that help support us in this effort. So as we're trying to solve this problem, and then we think about the preventability of the deaths that are currently occurring in the United States, it is easy to understand the role that blood pressure control has. However, when we look at the blood pressure control trends around the United States, we see that the trends continue to decline. And while this data is slightly dated, it's from NHINE's 2018 data, and we're looking forward to see the new data of the 2023, we still have a significant work that we need to do. There are over 100 million patients in the United States who have uncontrolled blood pressure. And talking from the strategy perspective, as we're looking at areas that we can improve cardiovascular disease, if we look across the different risk factors for cardiovascular disease, the data suggests that if we focus on improving blood pressure control, we're going to prevent more deaths and more morbidity and mortality related to cardiovascular disease. And this is the reason why AMA has been focused on improving blood pressure control over the last decade. So let's talk about the solution, and that is the AMA MAP Hypertension QI program that AMA team has built in collaboration with many different researchers and other institutions. Part of the work is to identify the problems that drive lack of blood pressure control. Blood pressure control is blood pressure measurement is error prone, so we need to measure accurately. Treatment intensification is happening very slow, and it's impacted by therapeutic inertia. We need to act rapidly. Our patients are not engaged, so we need to partner with patients. And when all of these three components come together, that's the best way that we can reach blood pressure control. It is these three elements that make the MAP framework. M, measure accurately, A, act rapidly, and P, partner with patients. Besides the framework, the program itself, has other components. It is based on evidence and specific action steps that can drive improvement in any one of the pillars that I just mentioned. We offer performance metrics and dashboard and monthly report that can drive success. There is a number of different supporting tools that have been built for both the clinical teams, but also for patients. And those are resources that are available to everyone on the call today. And really, they're open resources for everyone interested in arming themselves with some of these tools. The program also offers a quality improvement coaching. This is peer-to-peer coaching that comes to different healthcare organizations who partner with AMA to help drive success. And I'm going to spend a minute just to highlight some of the action items, some of the metrics, and we'll dive in specifically into the role of pharmacists. The strategies and the action steps for each of the pillars are identified in this slide. As you're going to see, we're going to focus more specifically in act rapidly, but I want to touch base very briefly on measure accurately, because that is a very important component of controlling blood pressure. When we talk about measure accurately, it's important that we're using validated, calibrated, automated blood pressure monitors. The patient position and preparation is essential, and really creating workflows to build confirmatory so that we can have confirmatory blood pressures is another action step that drives success. When we talk about partnering with patients, which is an area that pharmacists also know a lot about, this is where we talk about improving medication adherence, partnering with patients to help support them in their lifestyle changes, really focusing, using shared decision-making and collaborative communication, and promoting and creating programs that support self-measurement of blood pressure. And when we talk about act rapidly, these are two specific steps that are mentioned here are designed to help overcome therapeutic inertia. The other element of the program is the outcome and the process metric. The outcome metric for this program is the same outcome metric that CMS 165 metric that many of you are familiar with. What makes the program different, it's really the process metrics. The process metrics are designed to support any one of the pillars of our framework to help drive success in measure accurately, drive success in act rapidly, and drive success in partnering with patients. The program works. Later on in the presentation, I'm going to share a number of different publications that the team has put out over the last decade. And what I'm sharing here with you today is just one of the initial studies where 16 primary care offices were part of. And there's 2 points that I want to make here. Number one, a rapid improvement in blood pressure control. So over the 6 months that the team was engaged with the healthcare organizations, we saw a 10% improvement in blood pressure outcome. And what is the second point that I want to make is that that improvement was sustainable over the 12-month period, even though the AMA engagement with the healthcare organization had stopped at the 6 months mark. So what is that we have learned through the over a decade of journey? Well, there are key clinical care processes that drive blood pressure control. We mentioned inaccurate blood pressure measurement, therapeutic inertia, and non-adherence to treatment, including non-adherence to medications, lifestyle, and follow-up. So the program is designed to really provide solution to all these 3 elements. And we're going to focus specifically today on therapeutic inertia. I know that all of you in the call today are very familiar with therapeutic inertia and its definition as lack of treatment intensification when indicated. I'm sure that also you are very much aware that therapeutic inertia is impacted by a number of factors: health system factors, patient factors, physician, and other provider factors. We also know that these factors do not work alone, but they are dependent on each other. And overcoming therapeutic inertia, it is something that we're all actively working on. But what you may not realize is really the impact that therapeutic inertia has in blood pressure control. The data that I'm sharing here with you shows what percentage of patients with uncontrolled blood pressure which, by the way, for the purposes of this presentation, that's defined as a blood pressure above 140/90, which we know it is much higher than what the clinical goal for blood pressure is. But if we look at patients with a blood pressure above 140/90, which is stage 2 hypertension, based on this data, over 30% of them are on 0 blood pressure medications. Another 27% are on 1 blood pressure medications only. And landmark trials continue to tell us, study after study, that most patients will require more than 2 medications to get to goal. So this is one way of looking at the data and seeing the potential, or really the impact of therapeutic inertia in uncontrolled blood pressure. Another very significant data that I want to share with you here today, in particular speaking from the strategy perspective, as we're trying to improve blood pressure control, is the study by Bello and colleagues, which was published in 2019. This is a modeling study. This looked at medication adherence, the frequency of follow-up, and the treatment intensification independently and analyze the impact that each of them have in blood pressure control. At the time of the study, the blood pressure control rate was for our nation was at 46%. And as you can see, if we focus on improving medication adherence alone, the blood pressure improvement went from 46% to 57%. If we're working actively to bring patients in every week, the blood pressure control rate went to 68%. However, if we focus on intensifying therapy when indicated, and 2 out of the 3 visits that the patients have uncontrolled blood pressure, that alone is going to lead to a population health of blood pressure control of above 80%. So how do we overcome therapeutic inertia? Well, these are the 2 action steps that our program has designed. Number 1, use a combination therapy, preferably as a single pill combination. And what that means is that if you're working with a patient who has blood pressure control above 140/90, start them on 2 classes of medication. Or instead of slowly titrating the dose of the current medication, add a new class. Adding a new class of blood pressure medications had 3 times the blood pressure lowering effect when it's compared to increasing the dose of an existing medication. So you get a much more blood pressure reduction. And if you use a single pill combination, that treatment can be very patient-centered. And the second action step is using a hypertension medication treatment protocol. What that means is, what we mean by that, it's a 1-pager that can be as a tool that supports physician and other prescribers at the point of care. I also want to highlight some of the benefits of the single pill combination, because even though the recommendation to use combination therapy it's a guideline-based recommendation that it's been around for over 7 years now, we still see a very little utilization of combination therapy and specifically single pill combination. Well, the data is strong. Single pill combination means better medication adherence, better blood pressure reduction, which means better blood pressure control. When you use a single pill combination, you could start medication at lower doses and get a significant reduction in blood pressure. Lower doses means less adverse events. And then the last piece of information that is also very powerful is that when compared to the same medication classes given as separate tablets to the single medication, the CVD outcomes were positive, with a reduction in morbidity and mortality from cardiovascular disease. And as I continue to talk about the program and the different elements of the program, one thing has become very clear to our AMA team, and again, this is another concept that our audience here is very much familiar with. Team-based care is the solution, whether we talk about measure equity, acting rapidly, or partnering with patients. And where team-based care, and specifically pharmacists' role, becomes so important is in intensifying treatment intensification. So based on our experience, our role is to advocate and bring pharmacists into the space to be able to support treatment intensification, to support partner with patients. And what I have seen is pharmacists develop these services in the different models. There are pharmacists that practice at the population health level, at community pharmacy, and the clinic-based pharmacists, which is a model that we're very familiar with, and the impact that has on chronic disease management in general. So at this point, I'm just going to pass it to my colleague to focus a little bit more and speak to their model of population health services. Zach, I'm going to pass it to you.
Thank you, Claudiana. As was mentioned earlier, I'm Zach Crane. I'm the AVP of Clinical Administration at HopeHealth. We are a federally qualified health center. We have 16 practice sites here in South Carolina, mostly in the PD region. We have over 100 providers. We serve 60,000 or more patients, and we have mostly primary care, but we're also multi-specialty. So why do we partner with the AMA? Well, as many of you know, the Southeast is kind of the stroke belt of the country, and South Carolina in general is kind of the buckle of that stroke belt. And if we look at leading causes of death in South Carolina, we can see that heart disease is a significant portion of that leading causes in 2017 at least. And if we look at HopeHealth specific data, looking at RSR and population health level data, we have at least 14,000 patients when we partnered with the AMA that were high risk ASCVD, would be falling into that SPC measure. We had over 5,000 patients with uncontrolled hypertension. And then of those 5,000, 2,500 of them had no antihypertensive medication prescribed. So we realized back in 2021, 2020, when we were talking to the AMA, that we really needed a program that would help us focus on reducing cardiovascular deaths in our area. Just to give you an overview of our pharmacy services here at HopeHealth, we kind of have two branches. We have 4 retail pharmacy locations that offer 340B, specialty pharmacy, Ryan White services, and specialty drug channels. And then on the other end, we have a population health team that has pharmacists embedded on the value-based care population health team. And we have currently 3 pharmacist FTEs, full-time technician, and then a pharmacy resident. And the pharmacy team doesn't solely work on quality. We do see patients directly in clinic, and then we have some centralized services for drug information and P&T committee. But where the AMA MAP framework fell into place was really in the quality area of work that we were already doing for medication adherence and trying to improve efforts with controlling blood pressure. So what did we specifically do in relation to the AMA MAP framework? A big portion was clinical support staff education, part of the measuring accurately. A lot of clinical support staff here at HopeHealth were not repeating blood pressures. So we had multiple hypertension champions that would educate staff and work and MAs and nurses to ensure that if a blood pressure is elevated greater than 140/90, we need to repeat that blood pressure with intervals. And where the pharmacy team came in was really when we were doing chart audits on patients who were historically or chronically uncontrolled, identifying suites or areas or sites or individuals who potentially had missed that education and where there was opportunity for them to be retrained. And then looking at the act rapidly and therapeutic inertia, that was our biggest bulk of work, was looking directly at chart review, high risk patients, potentially also high ER, ED utilizers, and looking and see had there been an element of therapeutic inertia where potentially their hypertension had just been missed, or not even missed, but just their blood pressure medication hadn't been increased over a period of time. And I think where the AMA was particularly helpful with their data analytics was looking at blood pressure in light of average systolic, kind of like you look at an A1C is not a measure of time for just a fasting glucose, but it's a period of time, 3 to 6 months. And looking at blood pressure in the same way, instead of pulling a point in time blood pressure, looking at the last 12 readings over year to date or over the last 12 months and getting an average systolic. And we found that that was really beneficial with making therapeutic recommendations to provider. It seemed to hold more weight to them to say, you know, they were maybe not that high, or their blood pressure wasn't maybe that elevated today, but over the last 12 months, their average systolic's been above goal. Would you consider adding on this medication? And we had pretty good success with those recommendations. And then when it comes to the partnering with patients, medication adherence, as Claudiana mentioned, is such a huge area for improvement. We found that a lot of times there was a refill gap where providers were maybe giving 3 months to 4 months of refills, but then they scheduled the next follow-up 6 months. And so there was a month and a half where patients didn't have medication and they were just waiting till their next appointment. And so we were able to kind of identify that, especially with our Medicare population. Looking at some of the outcome measures with our Azara data, you can see that this is in the green is year to date. We have 20,000 patients with hypertension diagnosed. And if we look at the time period where we were partnering with the AMA in 2022, our control was around 74%. And this is even towards the tail end of our partnership with the AMA, where we are meeting with them monthly to look at hypertension control, but they were still providing good data for us. And you can see the upward trend line of how we have at least had a 6%, almost a 6% increase from baseline over the last 2 years. And in a population this large, it is quite difficult to move those percentages. So we've been super thankful for our partnership with AMA, and we've had good success. And another cohort that we looked at was looking at a specific Part D plan where we were able to obtain really good medication adherence data. And what we looked at was patients who in 2022 had failed their MAH or medication adherence, specifically on ACEs and ARBs, and they had failed that measure in 2022. And we wanted to see if in 2023, if we affected their medication adherence rates, would we see an improvement in their blood pressure control? And as you can see in 2023, this whole cohort passed their medication adherence, so they were compliant. And the number kind of aligns well with the data overall for AMA, but this is a particularly difficult patient. They're all Medicare patients, some are duals, and they historically have really poor medication adherence results. So it really speaks to the framework and the medication adherence efforts, and partnering with patients does work. And then to look at HopeHealth's blood pressure control, we're one of the few FQHCs that have partnered with the AMA on this MAP framework. And it just shows that in general, blood pressure control in South Carolina is poor. We're all not doing as well as we would like to do. We'd all love to be in the 90%. But with the AMA's help, we've really been able to improve our numbers and be one of the leading centers in South Carolina for blood pressure control as related to FQHCs. And we're kind of almost there to being the #1 in the state. So we'll keep working on it. I really wanted to focus on partner with patients. Medication adherence, I'm super passionate about. There's such a great need here with our population, at least. And if you're familiar with the STARS program at your center, you would this would look like a familiar chart to you. And I put a box around these measures because these are the ones where I feel like pharmacy has the biggest impact. You have A1C control, you have all your medication adherence, and then statin use. And that really makes up 50 to 60% of your star rating. So if you don't get 4 to 5 stars on these measures, you're really going to struggle to get a 4-star rating overall on your plan. And that's really where the value-based care incentives are based around that 4-star threshold. And in 2024, a lot of plans added controlling blood pressure and KED measure, looking for albuminuria and worsening kidney disease evaluation. And those, I feel like pharmacy has a really high impact as well. So that bumps that number up from 50 to 65%, where we can really impact the star rating and value-based care incentives. I wanted to show some success we've had with medication adherence, specifically for our largest plan. This plan had over 3,000 patients in it for Part D. And in 2021, we really didn't have anybody focusing on medication adherence. A lot of our population health team was kind of just looking at the screenings and the questionnaire. And we had a 3-star rating for this plan, so we weren't obtaining any value-based care incentives with them. But in 2021, towards the end of the year, I was able to join in on some of those meetings, and they'd said, well, we've tried to work on medication adherence, but no one can really touch that in this population. It's really, really challenging. And so that's all I really needed to hear for us to work on it. And we added a pharmacist to the population health team to focus specifically on medication adherence. And we were able to obtain a 4-star rating and start getting some value-based care incentives based on that 4-star rating and medication adherence. And so we also then added a pharmacy technician full-time, since we could justify that FTE. And in 2023, we had a 5-star rating across the board with that plan. And we saw a 400% increase in value-based care incentives, which would not have been possible if our medication adherence was not at that level. So I just wanted to talk about some successes and barriers. when we're thinking about interventions, we pretty much track any recommendation that we send to providers. And during this period of time, when we were making recommendations for hypertension control, we saw about an 88.6% acceptance rate. So using average systolic, using evidence-based guidelines, and it coming from a pharmacist holds a lot of weight in the eyes of the providers. And I think that really helped that acceptance rate and move that needle for therapeutic inertia. And then looking at financial sustainability, of course, I discussed medication adherence, but maybe unrelated to the MAP framework, another area for financial sustainability in the FQHC setting is adding on a prior authorization tech. It really increased access to drugs that were getting lost in the rigmarole of prior auths. And we have clinical pharmacy kind of owning that process from a centralized team. And it increased revenue and adherence. And that's another way to create some sustainability in an FQHC setting for pharmacy services, especially if you're getting 340B. Some barriers, of course, with any centralized pharmacy team, provider trust is a process. We've had a few years now to gain some provider trust, and we started with 1 or 2 providers sending us DI questions to now we have over 36 providers at about all of our sites sending us DI questions and communications on a weekly basis. Training was a huge barrier. A big part of this program is ensuring blood pressure is being measured accurately. And 2021 to 2022 for most likely all sites was just a high turnover rate coming out of COVID. And then being multi-specialty and multi-location, you have to have a lot of hypertension champions to provide that training. And you really have to repeat that training quite often to bring it to the forefront, because in primary care, they always have somebody asking to do something extra. And then currently we have no collaborative practice agreement in place. And I think that would have been helpful and would have kind of helped streamline the therapeutic inertia. But in 2025, we're hoping to add that to our services as well. And with that, I'm going to pass it over to Emily. Thank you.
My name is Emily. I'm a pharmacist at Grace Health, and Grace Health is a federally qualified health center. Our main site is located in Battle Creek, which is in Southwest Michigan. And just a little background before I dig into our pathway with the AMA. We began delivering primary care services to Calhoun County in 1986. And since then, we've really always tried to continuously grow to meet community needs. We have 12 additional sites located throughout Calhoun County, and that is including some of our school-based health centers. And we provide care to approximately 24% of Calhoun County. So we see about 28,000 patients per year. A little background on our pharmacy. We did open in 2018. Grace Health decided to expand our services to offering a full service pharmacy. It allowed us to just provide some of those more comprehensive pharmaceutical services we knew that our patients needed. Our retail pharmacy currently fills about 43% of Grace Health's patients' prescriptions, which comes out to about an average of 800 prescriptions a day. And we staff 6 pharmacists and about 15 support staff, and that is including some delivery drivers and some front staff clerks. Our pharmacy is rapidly growing. We are currently opening our 2nd pharmacy in collaboration with our mental health authority in Battle Creek. But we really did begin thinking about wanting to do more clinical pharmacy services in 2023. We just knew our pharmacists had more to offer outside of just the dispensing pharmacy, and our providers were very eager to start working with pharmacists as well. So just some background on some of the clinical pharmacy services that we wanted to do. Pre-AMA engagement, we really did mostly just some limited and more as needed or on the fly services, like as needed clinical questions or dosing questions or drug interaction questions. And these would be sometimes formal tasks in the EHR, but often just a Microsoft Teams message and day-to-day communication. So we did also start incorporating pharmacists into medication reconciliation after hospitalizations, especially for those complex patients that were at risk for readmission. And the providers and the clinical support staff did really love this, but it was never really a concrete program. So it did tend to kind of fizzle out over time and ebb and flow when it was utilized. We also touched a little bit in the diabetes space. We did some education on CGM and diabetic testing and insulin. But it really wasn't until our engagement with the AMA in 2023 that we really had a concrete program. So our quality department decided to partner with the AMA to help improve our blood pressure control via the MAP hypertension program. And we knew right off the bat we wanted to include a pharmacist in this process for blood pressure rechecks and medication intensification. So before this program, you know, everything was as needed and it wasn't really put into the treatment protocol. And once we partnered with the AMA, we really saw more utilization of the clinical pharmacy services more consistently, which related to better clinical outcomes. So this is data from Azara showing our blood pressure control less than 140/90. So that first picture is from 2022. We were at 68%, and that's when we really knew we needed to improve our blood pressure control. So we implemented some things like our quality care department would do some cold call outreach to patients that had uncontrolled blood pressure. But patients would really say, you know, my blood pressure is fine at home, or my provider didn't seem to be too concerned about it. And if patients were engaged in the phone call and got scheduled for an appointment, no-shows became an issue and patients weren't showing up for those appointments because it wasn't led by their PCP or their provider. We did other things like educating staff on the definition of what blood pressure control really is, education on doing repeat blood pressures, and we transitioned clinic-wide to an automatic blood pressure cuff in 2022 as well. So you can see in 2023, our control rate definitely did go up, it improved, but we weren't to our goal of 80%. So we were very hopeful that partnering with the AMA would get us closer to our goal. So like I said, we took this opportunity to partner with the AMA and knew right off the bat we wanted to include the pharmacist. So at the bottom of the slide, I kind of have a timeline of how our work with the AMA rolled out. We did meet with them over several months. It took about 10 months from our very first meeting to when pharmacists started seeing patients for blood pressure rechecks. So initially, we met with the AMA monthly. They started out by reviewing our current practices for controlling blood pressure, and they gave lots of recommendations and ideas for improvement. So in June of 2023, we completely restructured our Grace Health clinical pathway for treating hypertension. And this was done with a small work group. It was myself, our medical director, one other provider champion, and then RN from the quality department. We knew we wanted our pathway to be multidisciplinary and include members of the entire care team. So we went through our whole protocol from PCP to dietitians, to pharmacy, to support staff and community health workers. And we did just that. We really outlined steps and resources that all members of the care team could refer to while treating hypertension. And then within this protocol is where we developed the standardized blood pressure recheck with a pharmacist, which then also included a collaborative practice agreement for pharmacists to adjust the medications right then and there during that visit. So our pharmacist recheck program was successfully rolled out and implemented in January of this year. So we found the blood pressure recheck by a pharmacist was beneficial in several ways. Number one, it relieved our very busy nurse schedule. It freed them up for other things that we were falling short on, like Medicare wellness visits. And then when the blood pressure check was done with the nurse, we were never billing for this service. But when a pharmacist was doing it, there were some billing codes we could use if we paired the blood pressure recheck with a CMR or a complete medication review. So we were able to get some reimbursement for that. The pharmacist would then also do a medication reconciliation and update the meds in the chart. We found it very beneficial because pharmacists are really best suited to track medication adherence and really understand it if do medications truly needed to be added on, or is this maybe just a compliance issue and we need to address some adherence barriers. Lastly, the pharmacist would also perform education on medication compliance, even smoking cessation, lifestyle modifications with the ability to refer to dietitian, and then go over home blood pressure measurements as well. So this collaborative practice agreement and this appointment is made between pharmacists and our providers, and it really helped us to truly act rapidly and not miss the opportunity to intensify those medications when we have the patient here in the pharmacy getting their blood pressure rechecked. So instead of the patients going back and forth between the provider and the nurse and the clinical support staff, we were able to just send them home right away with that intensified medication. So just getting into kind of the nitty gritty of what our workflow looks like for this, we do have the provider first meets with the patient, has an appointment, identifies they have uncontrolled blood pressure, and they make a plan for the patient. So for example, they will say, you know, recheck with pharmacy in 2 weeks. If this is still uncontrolled, please add hydrochlorothiazide and recheck again in 2 weeks. And we too, just like Zach was saying, we've found and we know that provider trust is a process. And at the beginning of this, providers really spelled out exactly what they wanted done at each blood pressure recheck. But as time went on and providers start gaining trust and getting more comfortable with the pharmacist, we do see the acceptance rate go up for the recommendations given by the pharmacist. So before the patient leaves their appointment with their provider, they are scheduled with the pharmacist for the recheck. And that is nice because the patient is just more ready and more willing to come back and see the pharmacist. We saw that no-shows were less of an issue when the appointment with the pharmacist was recommended by their PCP. So during the blood pressure recheck, again, we're discussing those medication adherence barriers, if there are any, completing a CMR and billing if necessary, discussing any administration of meds, side effects, drug interactions, and then we also review the self-monitored blood pressure log. So this was another huge accomplishment that came out of partnering with the AMA. We did develop a policy in a way to track those home blood pressures in our EHR so that we could avoid failing to intensify medications when patients' blood pressures were controlled at home. Then lastly, we're able to intensify medications per our collaborative practice agreement right there during that appointment. And as we learned, and Claudiana spoke on at the beginning, we really always try to focus on those single pill combination products and focusing on the evidence-based treatment recommendations. And eliminating that middle work from back and forth between the RN and the provider is what helped us act rapidly to potentially have patients reach their blood pressure goals sooner. So this is where we are now with our blood pressure control measure less than 140/90. We still do have some work to do, but we have seen an increase since our partnership with the AMA MAP program. We've found out and understand that staff education is huge. You know, it was a learning curve for providers and for support staff to, instead of scheduling with nurses, start scheduling with pharmacists. So that's still education that we're still doing and still continuing to promote to hopefully soon the pharmacist would be the standardized procedure for blood pressure recheck. I did just want to show also our measuring accurately metric for repeat blood pressures. We did surpass our goal of 75% to 85%. So along with acting rapidly, we were really focusing on measuring accurately and getting those repeat blood pressures, and we did just that. So we were proud of this goal. And then lessons learned, like I said, building the trust with the providers truly does take time. They never, you know, right off the bat, they did not just hand over medication intensification to the pharmacist, but We are certainly seeing more trust from the providers that are interested and invested in the program, that are accepting those recommendations from the pharmacist. And then that staff education is continuous, and we are trying to move to pharmacists being the primary blood pressure recheck, but we're still promoting that. And then lastly, the solid framework from the AMA is really what helped us and the pharmacists have a true concrete place in the healthcare team at Grace Health. So, before we partnered with them, it was a lot of just as needed. Nothing really seemed to stick, but after partnering with the AMA and developing this program, we truly had our spot in the protocol in the treatment program for controlling hypertension. So, and now I will hand it back to Claudiana to wrap things up.
Yeah. Thank you, Emily. AMA MAP Hypertension QI program, it is something, it's a program that has been utilized and used in 50 plus healthcare organizations across the country. And we're looking forward to collaborating with more, with more healthcare organizations who are dedicated to improving blood pressure control. The program works, as I said earlier, and I think these are some of the publications that the group has put out that speaks to the sustainability of the program and the scalability of the program. The partnership that healthcare organizations get through their collaboration with AMA, it's focused beyond just improving outcomes or blood pressure outcomes. It is focused on improving efficiency within the care team. Actionable data makes the process and improves workflows that support that efficiency, and it saves money. I do want to note that the work that our team as IHO team within AMA does, it's work that is funded by the mission of the AMA. This is effort and support that comes to all healthcare organizations at no charge. We're here to support you on your mission to improving quality. And really, when you think about just like Zach and Emily spoke to, and in terms of how we do it, really we're looking at, number one, bringing all the stakeholders within a healthcare organization together. My role as a pharmacist within our team is to amplify the value that pharmacists have, and as a significant stakeholder when we talk about quality improvement in chronic disease management. And this is something that we have embodied into implementation of the MAP team. But that goes beyond just the clinical team, the physician, the pharmacist, the nurse. There is quality improvement, there is technology. So really knowing who are the stakeholders that drive and build quality improvement is part of our expertise that we bring to you. We also look at your organizations, your priorities, and the program that you already have in place, and try to build and offer flexibility in the way we work with different healthcare organizations. And really, the peer-to-peer coaching that the program offers, it's really appealing to all of the healthcare organizations that we work with. And while this program has been around for over a decade, we're still in the process of learning. We have great experience working with healthcare organizations that deliver healthcare, primary care offices, again, hospital systems. However, we know that quality improvement is happening in many different spaces, and we want to support you in your efforts. So if anything that you heard today sounds motivational to you, if you're in this space and you're trying to improve blood pressure control and move the needle beyond to the success that you've had so far, reach out to me, reach out to the AMA team through the QR code or the email that's here. The QR code that's on the slide will take you to the website where you can explore the different resources that are available to care teams and to patients. And again, we look forward to hearing from you and to help you in improving quality and improving blood pressure to your populations that you serve. And with that, I am going to pass it back to Amanda.
All right, thank you, Claudiana. Thank you, Emily and Zach. Really appreciate the conversation today. We do have a little bit of time for Q&A now. So I'm going to ask for all of our speakers to join us back here. We do have some questions coming in, want to get to as many as we can. I'm actually going to toss the first one to Zach, and I have a feeling that we've got quite a few audience members interested in this one. So Zach, you talked about the success that you all have had in improving medication adherence. And so we've got a question asking if you could talk a little bit more about what sorts of interventions you used. Did you have phone calls? What sorts of things did you do? And anything you can share on that would be fantastic.
Yeah, definitely. Yeah, I could probably talk for an hour or so about medication adherence. So specifically looking at our Part D plans that give us really good medication adherence data. Typically, the data is in a dashboard form, or they can send you like an Excel sheet. So a couple things that we really worked on was getting timely data. So some payers better than others, but you really need about a weekly cadence of updated medication adherence data that includes the pharmacy that it was filled at, the absolute fail date of the patient, because you get about 70-ish days, depending on when the patient was started on the medication, to cover them for the year. So if their absolute days remaining of how many days they can miss their medicine goes below 0, then they fail that measure. So you really have to have an up-to-date reporting. And our model is really to kind of triage patients. So we first look in the beginning of the year who failed last year, because let's look at them. That's kind of first quarter before you have really any fill data, because most people are getting 30 to 90 days. So January is kind of a wash because you don't really know who to work on. So we look at our fails. And then kind of as the quarters go on, we look at that absolute days remaining, and we filter the list based on who's most likely to fail. And what we found, which is really interesting, two big things. One, primary care is really bad at sending refills, and patients are really bad about asking for refills. So the first thing we always go do and look and see is there a refill at the pharmacy available for the patient? And if you know if you can get access to the clinical EMR, then that's where we start. And then we also, obviously, as pharmacists, look to see if the patient should actually be on the medication. So we don't want to be refilling things that they shouldn't be on if the provider stopped it. So once we know that the patient should be on it and that there's a refill available, we'll call the pharmacy, as long as it's not a mail order pharmacy, and say, hey, would you please fill this for the patient? The provider would like them to be on it. And what we found is if the pharmacy fills the medicine, they reach out to the patient to let them know it's ready, and the patients go pick it up. Very rarely are they putting those medicines back for maintenance medications. At least in our area. So it's not just patients that we've had success with our pharmacy. We'll call whatever pharmacy and ask them, hey, listen, like this patient hasn't been picking up their medicine, please fill it for them. Their provider wants them on it. And then for the first time in 6 months, they go and pick up their medicine. And we've really had good success with that. And then what we'll do is a week or two, we'll make an action. We use eClinicalWorks, so we can set actions for patients. We'll follow up with the data to see if the fill history kind of reconciles with when we filled it. And if it shows that they returned it to stock, then we'll go and call the patient and say, hey, the pharmacy filled it, looks like they returned it, and then we'll do some education on the phone. But I would say, talking to the technician, about 90% of the time, we never have to call the patient themselves because they go to the pharmacy and grab the medicine. So that's where we found a lot of success. And of course, there's tweaking here and there, but in general, that'll set you up for a good model. Hopefully that gives you a starting point.
Absolutely. Thank you, Zach. That's a lot of practical information. Not necessarily what I would expected. So thank you for sharing those insights. Appreciate it. Emily, we've got a question for you, and it relates to codes that you use to bill for blood pressure rechecks or any of your other services. Are you able to share like how you use codes, maybe what those codes might be or anything around that?
Yeah, so it's definitely going to depend on the state you're in and what's allowed for billing, but we don't bill for the actual blood pressure recheck. We would bill for an MTM service or a CMR if that was completed along with the blood pressure recheck. So we use the MTM billing codes 99606 and 99607.
Okay, Perfect. Thank you, Emily. We've actually had another question come in for you, so I will just go right for this one. You were talking about the importance of tracking blood pressure at home and tracking that in the EMR. Is there anything that you can share about the processes or the devices that enabled you to incorporate that at home blood pressure data into your EMR?
Yeah, so we did a lot of work with home blood pressure monitoring. We got feedback from our providers when we talked about, you know, patients coming in and they have a high blood pressure, and why did we not intensify meds? One of the biggest answers was, well, their blood pressure is fine at home. And we had no way of really recording that. So we did start asking our clinical support staff to log an average of the last 10 home blood pressures, and this was patient reported if they had a log and it was written down. And then we also have them bring in their home device and have them take a blood pressure on it in office so we can confirm they're taking it correctly. And then it's giving consistent answers with what we were getting in the clinic as well. So it's not any sort of like remote patient monitoring where we're getting real-time data. It is still a log that we're depending on the patients to bring in, which can be hit or miss, but we've had success with it.
All right, wonderful. Thank you, Emily. Claudiana, I'm going to go to you with this next question. I'm curious about perhaps some challenges and barriers that you've noticed that healthcare organizations have faced implementing this program, and maybe some things you've seen to overcome them. If you've gotten that far, what are your thoughts on that?
Yeah, thank you very much. I think one of the first challenges that healthcare organizations have is just prioritizing the different quality metrics that they're working on. As everyone in the audience here knows, the number of quality metrics is very long, and making hypertension a priority, it's not always easy. And the way we've overcome that, it's by identifying champions within the healthcare organization. If from the pharmacy perspective, there is always pharmacists who are very passionate about this work, but from the medical team, there is always we need a physician leaders who can champion the work. And once those two are in place, that's where the work really starts. Other challenges is really the concern that a lot of healthcare organizations express is, how would I make this possible? The time that it will need to actually make all the changes that are recommended seems significant. And that is actually a perceived challenge, because once you get to the actual work that is happening in the clinics, and you can see how many inefficiencies are actually happening, we're creating the workflows and working with the teams and bringing the stakeholders together. It's very, very quickly the teams are able to see that the time that's dedicated to this is not as big as they originally thought. And then the third challenge, that is a challenge that continues to be, and I look forward to collaborating with more pharmacists to resolve this, it's really overcoming therapeutic inertia. Act rapidly, it is definitely a measure that is harder to reach and to meet the goals for. Bringing the pharmacists into this workspace has been one of the solutions that has really improved and made progress into advancing therapeutic treatment intensification to help with blood pressure goal. However, it's still not where it needs to be. So we have a lot of learning that we need to continue to do there. And this is what it's an area that I'm very much interested in. And this is something that, again, team-based care, it's right now the only solution that will help us overcome that. And pharmacists at the center of it.
All right, thank you so much, Claudiana. Yes, lots of learning still to be done, but lots of great progress being made as well. I want to thank the audience so much for all the questions. Unfortunately, we're not going to have time to get to any more today, but also like to thank the three speakers for joining us today. I've really enjoyed the discussion. I hope you all enjoyed that as well. And so if we could bring the slides back up here, I've got a few closing announcements to wrap us up today. Gonna drop a couple of things in chat for your reference. First of all, I would like to let everyone know, in case you didn't already, that registration is open for the PQA Convenes and also the 2024 PQA Leadership Summit. Both of these events are going to be happening this year in Arlington, Virginia. PQA Convenes will take place on November the 7th, and it will bring leaders in the rare disease community together to discuss quality medication use. And then the Leadership Summit will take place on November 7th and 8th, and its focus is on PQA's recent and ongoing work to develop standard pharmacy quality measures. We have sent registration information for both of these events to the key contact for each PQA member organization. If you do have questions about either of these events, please reach out to us. The email is in the chat, but it's meetings@pqaalliance.org. And then secondly, the call for breakout session and poster abstract proposals for the 2025 PQA annual meeting are both now open. This meeting is going to take place May 19th through the 21st. It will be in Tampa, Florida. The first due date is for the session proposals, and that is on Tuesday, November the 12th. So that will be coming up here pretty quickly. And then the due date for the abstract proposals is Friday, January 10th. You can either submit a proposal or find more information at that link that I have posted for you in chat. And then next, please join us for our next stakeholder advisory meeting. It's going to be coming up pretty soon here on Wednesday, October the 23rd at 1 p.m. Eastern Time. Registration information for this event is available to PQA members in the Member Resources Library section of the PQA website, or you can watch your email for updates as well. And we look forward to seeing you at the stakeholder advisory meeting. And then our next Quality Forum webinar will be held on Thursday, November the 21st, also at 1 p.m. Eastern Time. This Quality Forum is a members only event, and our topic will be the Medicare 2025 Star Ratings Update. This webinar is sponsored by PQS by Innovacer. Registration information is available once again to PQA members in that Member Resources Library, and you can also watch your email for updates on this webinar. And then finally, I'd like to thank once again PerformRx for sponsoring today's webinar. PQA is grateful for your support. And to all of you, thank you so much for joining today, and I hope you have a great rest of your day.